Let's kick off this explainer with an uncomfortable but absolutely essential strategic question. Are our healthcare systems failing to communicate, or are our patients just failing to understand? For those of us in healthcare leadership, we already know that clinical excellence alone doesn't guarantee optimal outcomes anymore. Today, we're diving deep into organizational health literacy. We're going to unpack exactly why structurally transforming your institution into a highly navigable, health-literate organization is quite literally one of the most critical, evidence-based strategic moves you can make to elevate the standard of medical care. Here's our roadmap for this explainer. We'll start with the healthcare complexity problem, move on to defining organizational health literacy, outline the 10 HLO attributes, compare global implementation frameworks, and wrap up with the executive mandate. Section 1. The healthcare complexity problem. Think about the root cause of poor health outcomes for a second. Historically, the medical establishment kind of viewed health literacy as a patient deficit, right? Like it was a personal failure to decode medical jargon or stick to a complicated medication schedule. But the modern academic consensus flips this paradigm completely upside down. The friction isn't just the patient. It's the sheer, overwhelming systemic complexity of our own institutions. It really comes down to weighing situational demands against individual capacity. Picture this. You have a highly educated professional who has just been handed a terrifying diagnosis. In that moment, their individual cognitive capacity is practically crippled by fear and stress. Now, if the situational demands, like navigating a labyrinth of a hospital wing, trying to coordinate fragmented specialists, or just deciphering complex discharge papers, if those demands exceed their diminished capacity, well, the system has failed. We absolutely have to structurally lower those situational demands. Section 2. Defining organizational health literacy. In the past, hospitals would try to screen for patients with low health literacy to give them a little extra help. But the research now points us toward a universal health literacy precaution, treating it as a formal, clinical-grade protocol. Instead of trying to isolate specific vulnerable groups, we need to adopt universal precautions. Basically, treat every single patient as if they might misunderstand. By making our systems universally comprehensible, we remove the stigma and we catch everyone who might just be temporarily overwhelmed. So let's nail down the formal definition. Organizational health literacy, or OHL, is essentially how our services, organizations, and systems make health information accessible to people tailored to their specific limitations. Think of OHL as your strategic methodology. It's the concrete protocols, the digital interface designs, the systemic cultural shifts that we deploy to guarantee true accessibility regardless of a patient's background. And building right on top of that, a health-literate organization, an HLO, is the tangible results. If OHL is the strategic methodology, the how, then the HLO is the ultimate organizational goal, the what. It's the actual institution that has successfully engineered a seamlessly navigable environment where patients can easily understand and actually use health information to manage their care. Section 3, the 10 HLO attributes. To actually achieve this concrete transformation, we rely on the Institute of Medicine's 10 attributes. Now, for the C-suite folks, these first 3 are your direct mandate. You've got to embed health literacy directly into your mission statement, tie it hard to your quality improvement metrics, and hold your leadership accountable. It demands continuous, systemic workforce preparation. We're talking about training everyone, from your top neurosurgeons right down to the front desk receptionists, in clear communication protocols. On the operational side, attributes 4 through 10 require a real physical overhaul of the patient experience. This means actively co-designing materials with the actual patients who use them, rolling out plain language media, and making sure physical hospital navigation makes sense. And crucially, it means mandating verified communication protocols, like the teach-back method, especially during high-risk transitions. We have to actively verify understanding at every touchpoint, rather than dangerously assuming it's happening. Section 4. Global Implementation Frameworks. Now, while the US-based Institute of Medicine framework is incredibly foundational, it does have a distinct clinical bias. It focuses primarily on patient treatment, but global academic consensus has evolved past that. The Vienna concept and its international successor, the OHL-HAS, actually originate from the World Health Organization's Health Promoting Hospitals Network. This modern framework expands the scope entirely. It uses a setting-based approach to raise the health literacy of the physical hospital environment itself, the staff, and even the surrounding community stakeholders. For the executives out there who are laser-focused on metrics, get this. The international OHL-HAS framework boasts 156 rigorous indicators across 8 different standards. This proves that OHL isn't just some soft, abstract concept. No way. It is a highly measurable, data-driven operational initiative. It literally empowers your quality improvement teams to execute precise self-assessments and drive systemic upgrades. Section 5. The Executive Mandate. Look, implementing OHL is not a one-and-done project, and it's definitely not a brief marketing campaign. It requires a continuous quality improvement cycle. It starts by forming dedicated multidisciplinary teams. From there, you set strict, measurable aims, assess your baseline using those 156 indicators, develop a rigorous action plan, and just continuously test your changes. Honestly, it utilizes the exact same continuous improvement methodologies you're already using for things like infection control or operational efficiency. Research highlights 5 core implementation principles here, but the absolute most vital one, core business integration. You have to treat this as a systemic, organizational-level intervention. If you try to treat health literacy as a siloed afterthought, or if you just delegate it entirely to the patient education department, it's going to fail. It has to be woven into the very DNA of your clinical operations and your external partnerships. Of course, transformation always faces friction. That's just reality. Academic studies prove that the primary barriers to actually becoming an HLO are a lack of executive support and restricted resources. So, successful implementation absolutely requires highly visible leadership, dedicated financial budgets, protected time for staff training, and the active cultivation of internal change champions. At the end of the day, your leadership is the ultimate deciding factor. As we wrap up this explainer, I want to leave you with one vital, provocative question to pose to your own executive boards. Has our leadership truly integrated health literacy into our institutional mission, our structure, and our daily operations? Shifting that burden of understanding away from the vulnerable patient and onto our highly capable systems isn't just an operational upgrade. It is a strategic and moral imperative. Take a hard look at the OHL HOS framework and ask yourself what it will take to structurally transform your institution today